The hematocrit is usually a 1-to-3 ratio, and in women, the normal range is anywhere from 38 to 46, and for men, 42 to 54. Also in the blood cells are white cells, which we know as leukocytes, and they defend the body against infection. They help remove debris. Their normal range is anywhere from 4.8 to 10.5, depending on the reference lab. And I refer to the white cells as an umbrella for all the specific white cells that are further listed in the differential, and we're going to go over those. The first one we're going to talk about is your neutrophils, and those are your chief phagocytes. They ingest bacteria and other material in the blood. Their life expectancy is anywhere from 1 to 2 days. The next are your eosinophils. They perform phagocytosis, but they ingest antigen-antibody complexes that are induced by IgE. These cells will be elevated if you're having an allergic hypersensitivity reaction. Your basophils are the cells that are similar to mast cells, and they're involved in the inflammatory process, especially with allergic reactions. Your monocytes are formed and released by the bone marrow into the bloodstream. As they mature, they migrate to a variety of different tissues, such as the liver, the lymph nodes, and the spleen. They attack bacteria, fungi, and viruses. Elevated monocytes in the elderly need to be considered a referral, as this could be the beginnings of a leukemia, specifically chronic myelogenous leukemia. Lymphocytes circulate in the blood and they reside in the lymphoid tissue. There are two different types: the B cells, which produce antibodies used to attack bacteria, toxins, and viruses, and then the T cells that destroy the body's own cells that have been taken over by viruses or ones that may be cancerous. The last one in a CBC that we're going to talk about are your platelets. And we know that they're essential for blood coagulation and the control of bleeding. The normal range is anywhere from 150,000 to 400,000, depending on your reference lab. So we know that all of our blood cells are produced in the bone marrow. When they are formed, they are undifferentiated, and the type is determined based on the need of the body at the time. The regulation in cell development is controlled by erythropoietin, which is found in the bone marrow, and a smaller extent produced by the kidneys. Normal development of the erythrocytes and the synthesis of hemoglobin is all dependent on what it has to develop and nurture those cells. So it needs necessary building blocks to grow, and those include proteins, vitamins, and minerals. So if these components are lacking for a prolonged period of time, then the red cell production may slow and anemia may develop over time. We're going to first talk about alterations in erythrocyte production. The first thing that we would think of might be the underproduction of red cells, and that could be caused by impaired red cell production, blood loss, whether it was acute or chronic, increased red cell destruction, or a combination of all of the above. We know that anemias are classified based on their cause or by the change in the size or the shape of the cells. Common terms that you may see on reports from the lab are talking more about the size of the cells. If the cells are abnormally large, those are considered macrocytic. If the cells of the red cells are normal in size, those may be considered more normochromatic, even though the hemoglobin may be low, and you may see those in pernicious anemia or folate anemia. And then you can have the small cells, which would be considered microscopic. And microcytic cells are small, abnormally shaped red cells. Three anemias that we're going to talk about are your iron deficiency, your vitamin B12 deficiency, and anemia of chronic disease. Anemia that is mild and starts gradually is easier for the body to compensate for than someone that has been in an accident and has lost a large volume of blood. As red cell production decreases, symptoms may be more pronounced and impact specific organs. The body's going to learn to compensate, and that those compensations are going to be seen in your cardiovascular, your respiratory, and your hematologic systems. When there's a reduction in red blood cells, you're going to have a reduction in volume of blood as well. The difference is going to be made up with plasma that the body is going to produce that's going to help to maintain the volume. With that increased plasma, there's also a decreased viscosity of the blood, and so it's going to be thinner and it's going to flow quicker, and this can cause a hyperdynamic state that may lead to an increased respiratory rate. When the tissue is not receiving enough oxygen, it's going to trigger a compensatory mechanism that may cause shortness of air. As we talked about the rapid bounding heart rate, your patient may have dizziness or fatigue. And in chronic cases, these symptoms may be only seen when there's exertion on the body. So the first one we're going to talk about is iron deficiency anemia. It's the most common type of anemia worldwide. It is seen in both developing and undeveloped countries. Women of childbearing age have a higher incidence than males for low iron and iron deficiency, and this peak is noted during the reproductive years and can be attributed to heavier periods and also for women during pregnancy. Iron deficiency anemia is also seen in individuals living in poverty due to nutritional stores, and then for children as well. Some of the clinical manifestations of iron deficiency anemia are low hemoglobin and hematocrit. You may note some pale earlobes, the mucosa in the mouth may be pale, the conjunctiva may be pale. You may notice that there are differences in the nails. They may be brittle, spoon-shaped, and this term is colonychia. You also may note that your patients may have some pica or pica. I have noticed quite a few patients that want to chew ice when their iron levels are low. Other symptoms may include fatigue, leg cramps, and a cold intolerance. We're going to look here at what a normal cell looks like. This is a picture of normal cells, and they're relatively uniform in size. They have a center of paleness, which is normal, and this is approximately a third of the cell diameter. When you look at the iron deficient cells, they are smaller in size than normal, and I believe that this is a closer look than the other ones, and we can't quite compare side by side, but you notice that their nuclei are paler and larger than the previous slide that we looked at. So how are you going to evaluate your patient if you have concerns for iron deficiency? The first thing that you need to order is a CBC. That's going to give a lot of information. We're going to look at some of those labs here in a moment, but you also want to check an iron and a TIBC. You want to order a ferritin, and you might possibly want to order a blood cell peripheral smear. It's important that you're going to want to rule out if there's been any significant blood loss, evaluating bleeding from the rectum, evaluating if they're having heavy periods, if they're having clotting with periods, if the duration of the period is longer than what is typical. In iron deficiency, this is a microcytic anemia, so as we talked about, the cells are smaller, and on a CBC, the information that gives us that is the MCV, which is the mean corpuscular volume, and with iron deficiency, it is typically the size of the cells is often less than 80. You can see various scenarios, and some of the other labs may be normal, but the MCV may be low as well. So it's learning to feel more comfortable with those labs so you can make determinations based on what you see. When you're evaluating for iron deficiency, we talked about blood loss, but it's also important to evaluate, has there been any issues with poor absorption in the past? Is the patient on a PPI, something that's going to impact gastric secretions? And also, have they had a history of gastric bypass surgery? With that, the absorption abilities of the stomach are different depending on what surgery they've had done. If you find a patient that is iron deficient, your first option for treatment is going to be oral replacement. You can give ferrous sulfate or ferrous gluconate. Those are known to be the best in the over-counter classifications. The frequency that you will give the iron supplement will be based on the blood levels and the symptoms. You could give it once a day, twice a day. I've had patients that's been on 3 times a day. It's very important though that iron be taken with vitamin C or a food that's high in vitamin C, such as certain vegetables, a V8, etc. This helps in the absorption of iron and helps it get transported into the cell more effectively. We talked earlier about the life expectancy of the red cells being anywhere from 90 to 120 days. So you're not going to see a sizable improvement in labs overnight. If you have someone that has very low counts that you're worried about and you're starting on iron, rechecking in about 6 weeks would be very appropriate, and as long as they are trending upward towards more normal labs, then continue what you are doing. We know that oral iron can cause constipation and stomach upset. So if there's stomach issues and your patient is trying it on an empty stomach, have them try it with food or to change the preparation of it. Iron comes in many different forms. Sometimes just changing a brand can make a difference, but iron is also made as a liquid. And then there's also vitamins that are available for the bariatric population, and that may be something that your patient needs to consider. Patients will often report that they've had a big improvement in symptoms as they start on the oral iron if it is working for them. So always be sure and review a good HPI on their energy levels. Are they having to nap during the day? Are they having any shortness of air? Things like that, shortness of air on exertion after you bring them back in for an evaluation. We're going to look here briefly at some labs. We're not worrying about the WBC, but you can see here, actually this probably isn't the best one that I would like for this, but you can see that we have a hemoglobin of 9.9 that has fallen in a short period of time. Their platelets are also elevated. Platelets are a very reactive cell. If there are other concerns going on in the body, they can react to what might be causing that. So having this elevated platelet is not a big concern to me. You can see from December though that it's trending down. This next slide has some ferritin levels and some iron levels, and if we go over and look at back in February 2016, you can see that their ferritin, which is the stored iron, was low. I anticipate in July of 16 they received some boost of iron, and based on the increase from April to July, I anticipate that was some IV iron, and it continued to rise, but then it started to settle down. And you can see over approximately the 18 to 20 months, it has now returned down to a lower level. Now, while 32 is still considered within normal limits, you can see how it's trending down. And these labs are from the same patient, and you can see where they may not be in the same patient. I apologize. You can see with this patient that the iron had been up, and over a 6-week period it had fallen significantly. So these are showing that the iron had fallen in a short period of time, and the saturation level had fallen, the ability of the blood to absorb the iron. Let's talk next about vitamin B12 deficiency, and that is considered a macrocytic anemia, and these are usually vitamin B12 issues. Labs that we would use to check this would be a CBC, a vitamin B12, and a reticulocyte count. This lab is going to tell you the new number of blood cells that are produced in the body. Vitamin B12 deficiencies are typically slow developing. The two that you may often hear about is a vitamin B12 deficiency, and then also pernicious anemia. Pernicious anemia is where the body has an impaired intrinsic factor that's secreted by the parietal cells in the stomach that doesn't allow for absorption. Although both of them have the same treatment of being supplemented with vitamin B12, pernicious anemia though requires lifelong treatment. So as we talked about, this is a macrocytic anemia. The hemoglobin is big and puffy. The MCV is often high, usually greater than 100, and we'll look at some labs here in a little bit. Symptoms may often be ignored because they are nonspecific and vague. Your hemoglobin can fall to a low range, 7 to 8, and the patient may experience classic symptoms of anemia. Without B12, the red cells can't divide, and therefore they stay large and cannot move through the bone marrow. B12 is also very important for nerve conduction, and so if those levels are low, they can cause issues with numbness to hands and feet. We talked about the initial test that you would use for those. Treatment of choice would be cobalamin, which is vitamin B12. You could start with oral supplementation, 1,000 micrograms daily, and I recommend finding a preparation that is sublingual. Have your patient put it underneath their tongue and let it dissolve. That offers better absorption. If you are feeling that your patient needs IM, depending on what the level is, you might try starting vitamin B12 daily for 5 days, then weekly for 4 weeks, and then every month. It's important to assess these labs about every 3 months, as we talked about with iron deficiency. This patient that we're seeing on the screen, so a long time ago, had been receiving vitamin B12. Their labs came up higher than normal in the greater than 1200 range. They ebbed and flowed. Back in October of 17, their labs were again below normal. This is a patient that was not compliant with receiving vitamin B12 shots, and even though these low ones, this 299 is within normal limits, this patient was having a lot of issues with fatigue and some numbness to her hands and feet. Next, we're going to talk about myeloproliferative disorders. This is a hematological dysfunction that results in the overproduction of cells. It can be a result of exposure to radiation or drugs, a physiological response, and also immune disorder. It's characterized by the overproduction of one or more of the hematologic lines in the peripheral blood. It could be your white cells, your red cells, or your platelets, and it is not indicative of an acute leukemia at that time. So for the purposes of our talk, we're going to talk about polycythemia vera and iron overload and hereditary hemochromatosis. As we talked about, it can be the result of radiation exposure, drugs, a physiological response. In these patients, they have a specific mutation that is noted on their genes called a JAK2 gene mutation. They have an increase in the red cells, which also indicates there's an increased thickness to the blood. They may present with a reddened face, have headaches, drowsiness. They may have vision issues. These patients may have an enlarged spleen, or they also may have an enlarged liver, and these two findings may result in abdominal pain and discomfort. When you're evaluating for this condition, you have to be looking for, has there been any thrombotic event? Does the patient have any splenomegalia? There's a condition called aquagenic pruritus, and it's a skin disease that's characterized by significant itching when in contact with water, but there aren't any visible lesions that are seen. The cause is unknown, but it is associated with polycythemia vera. Your hematocrit is elevated anywhere from 18 to 24. Treatment includes reduction in the red cell and decreasing the blood volume. This is typically done with phlebotomy that can usually be anywhere from 250 to 500 milliliters depending on the patient and depending on what your lab levels are. It's important with this disease to control the symptoms. You also want to decrease any potential of the increased volume of cells clogging or causing a clot in the vessels. So it's important for your patient to stay hydrated, and these patients are often on a low dose of aspirin to help thin out the blood. A treatment that you may see used in polycythemia vera is the use of a medication called Hydrea. It is a myelosuppressive drug, and it's used in the treatment of this condition that is not controlled by phlebotomy. Just looking at some labs, you can see the white cells are elevated in this profile. The hemoglobin is for this gentleman a little bit on the low side, but they have quite high platelets. They're typically running in the 800 or 900s, and at one point at this time they were greater than 1,000,000. So that is a concern for, as we talked about earlier, the potential to cause clots. In iron overload, there are two types, primary and secondary. Primary is referred to as the hemochromatosis, which is a common inherited autosomal recessive disorder of iron metabolism. Secondary iron overload is caused by iron overload due to anemias, dietary overload, or repeated blood transfusions. Iron overload related to blood transfusions may require a chelation treatment that will pull the excess iron out of the body, and an example of that is a medication called deferoxamine. So with primary hemochromatosis, it's one of the most common genetic disorders in the U.S. Approximately 1,000,000 people have it. It accounts for hereditary hemochromatosis accounts for 90% of the cases, and it is a mutation that is found on chromosome 6 and is only present in the white population. There are a few other hemochromatosis conditions, but they are considered very rare. We know that this is an excessive iron absorption. We know that with that iron absorption, iron is deposited in the liver, the pancreas, the heart, joints, and in the endocrine glands. And when it collects there, it can cause tissue damage. We know that it affects males more than females. Most patients are symptomatic, approximately 75% of them. Early symptoms may include fatigue, impotence, arthralgia. If you're concerned and want to check do labs for this patient that there might be too much iron, CBC, iron transfer and saturation levels of ferritin, and an HFE mutation analysis. Treatment, as we talked about, is typically phlebotomy, 250 to 500 milliliters. Depending on what your level is, will depend on how often that is going to be removed. And at this point, I should have mentioned this earlier, at this point these diagnoses are being made by a hematologist, but you may be receiving notes, you may be assisting if it was a hematologist that's outside of your area, so that's why I'm giving you this information. You're wanting to keep the ferritin level low, so anywhere from 20 to 50 on that level is where you're going to want to keep that. That does not mean that they have iron deficiency though, because you're trying to keep them low. You're trying to keep those numbers down so that the ferritin does not deposit. It's very important to have your patient be aware of the nutritional needs of hemochromatosis. There are specific diets out there that help and educational information to help know what foods are higher in iron and what to avoid. It's important to avoid vitamins and iron supplements and avoid vitamin C supplements because those help increase the absorption of iron. But you do not need to have your patient restrict vitamin C in their diet, avoid alcohol or shellfish. Some folks ask, well, why with all this excess blood can it not be donated to, for example, the Red Cross? The primary reason is it's not being collected by a Red Cross collection center or donated in a manner that is suitable then to be given to someone else. There's also no evidence that a hemochromatosis patient would have complications related to that versus a non-hemochromatosis patient, but there are two studies that suggest that iron overload patients may be more susceptible to bacterial growth, and there's more studies being done, and so therefore you would not want that blood to be given to someone that was in need of a blood transfusion. Here are some labs for some hemochromatosis. So you can see that this person was in the high 400s. They began having phlebotomy, and over time, you can see by the dates how often their labs were checked. But the ferritin is coming down, and this gentleman did receive phlebotomy again that day for his ferritin level being greater than 50. Let's talk next about alterations in leukocyte production. So that's the underproduction or the overproduction of white cells. The overproduction is called leukocytosis. The underproduction is called leukopenia. Remember also we talked about the different white cells that make up the overall white cells. And so those are the cells that are seen in a differential, and I believe we'll be looking at that here in a little bit. Here are some labs that for leukocytosis. So you can see that the overall white blood cell count is elevated, and the neutrophil percentage, which we know are the leukocytes, also known as SEGs, those are elevated. This is an example of leukopenia, where the white count is low even though they have a normal finding for their neutrophil count. So let's talk a little bit about leukopenia. We know that they're white cells that are lower than normal. They are associated with a decreased ability to fight infection. You may hear the term neutropenia, meaning a decreased number of neutrophils, and I use this a lot in practice, but this refers to your patient's ability to fight infection, and there's a calculation that you can do, and we're not going to go into this. I just put it here as a reference should you need it in the future. But you would take some differentials include bands in their differential, but you would take the SEGs and take a percentage of that and multiply it by the white blood cell count and get a particular number, which is called your absolute neutrophil count. An absolute neutrophil count greater than 1500 is considered normal. Between 1000 and 1500 is mildly compromised. 500 to 1000 moderately, less than 500 severely compromised. Most of our neutrophil counts are up there in the thousands depending, but 3,000 or 4,000. So this is just more information if you should have a patient who has low blood counts. We're going to go back. I skipped a slide. Let's talk about leukocytosis. This is an elevated white count. We would check for a CBC with a diff to assess this. There are many stressors that might impact your white count. This can include microorganisms. Your white count can rise related to strenuous exercise, emotional changes, temperature changes, if you've had anesthesia surgery, if you've been pregnant or are currently pregnant. It can rise related to drugs, hormones, and toxins. Let's next go back to platelets, and we're going to briefly talk about three: thrombocytopenia, low platelets, immune thrombocytopenia purpura, ITP, and thrombocytosis. So thrombocytopenia is low platelets, typically less than 130. It's not a decreased significance unless your platelets are less than 100,000. This condition can be caused from decreased platelet production, increased consumption of platelets, or both. The life expectancy of platelets is approximately 7 to 10 days, so they are impacted very easily by what's going on in the blood. You can have a risk of bleeding if your platelets are less than 50,000. You can have spontaneous bleeding for platelets less than 10,000. Acquired thrombocytopenia is the most common type of thrombocytopenia, and it's secondary to viral infections to certain drugs, including your thiazides, your estrogens, NSAIDs, certain antibiotics, Zosyn, penicillin, sulfa drugs. Next, your ITPs, it's formerly known as idiopathic thrombocytopenia purpura, and it's an immune response. It is typically considered a chronic disease. and it's where you have an antibody-mediated destruction against a specific platelet antigen. It's going to be seen with bruising or bleeding or petechiae and purpura. I'm going to show you a picture of that. Likely you have heard of that before. Initial therapy when this is diagnosed is started with prednisone, 1 milligram per kilogram for 4 days, and this helps suppress the immune response. If that is unsuccessful and labs are checked afterwards unsuccessful, IVIG may be considered, and then there's several medications on the market. One, an oral medication called Promacta to help increase the platelets. So there's lots of options on helping to have your patients help increase their platelet count. Our threshold is 50,000. If your patient's platelets can stay above 50,000, then we do not do a medication intervention. But these patients do require monthly CBCs to assess their platelet count. This is a patient that has chronic ITP. They get their platelets checked approximately every month, and you can see that they stay in this high 70s to 90 range. They are not on any medication, but they have to be very careful and cautious about injuries. They're aware to call for any increased bruising or bleeding. These are also patients that I educate that if there was an injury, if there was a fall, especially dependent on age, and if they hit their head, that would require an ER visit, as there could be a subdural hematoma. We are almost done. This is just some pictures if you are not familiar with what petechiae and purpura look like. And this is where blood has seeped out into the underlying tissue, often from capillaries that leak. But pictures of both of those. Lastly, we're going to talk about thrombocytosis, and we talked about platelets being very reactive, but this is a chronic myeloproliferative disorder where the megakaryocytes that are part of the platelet production have help increase circulating platelets in the blood. It is typically for blood platelet levels greater than 450,000. You can have splenomegalia and you can have hepatomegalia with these patients. Most individuals that have elevated blood counts have an associated genetic mutation. Most are asymptomatic. The symptoms are often related to small or large vessel occlusions. There can be microvascular occlusions that can cause pain in the fingers or the toes, and you may see that patients describe it as a burning sensation, and they may have duskiness in the color of their fingers and toes. The pain may increase with heat, and it may improve with cold. Aspirin is often used to thin the blood out to help with these occlusions, and it's also important, as we talked earlier, about these patients staying well hydrated, and the patients need to be well educated on the signs and symptoms of clots in larger vessels. Okay, so we saw one similar to this before, but this is someone who has thrombocytosis. You can see on some previous labs that they had greater than 1 million. I do not remember why they have gone from 1 million down to 500,000, but I believe that this patient was on Hydrea, and the reason that I say that is if you look up here at the MCV, their cells are big and puffy, and that is a known sign of hydrea, that you have macrocytosis. Over here, you can see that we're still up in the millions, and their MCV was normal. So here they've started to rise, and I attribute that to their hydrea. The last slide is if you have a patient that needs to ever be seen in a hematology oncology practice, educate them that it's going to be no different than any initial appointment. There's going to be a health history conducted, lots of specific questions, a physical exam, review of previous labs. There may be more labs drawn and a plan formulated with discussion of what the next steps are going to be. Sorry for the length of the video. If you have any questions or concerns, please let me know. Thank you.